Thank you so much for this beautiful presentation. If there aren't other questions, I introduce my friends and colleague, Youssef El-Dsouki, Senior Clinical Perfusionist from Sorbonne University, with the topics of advances in perfusion technologies, introducing the new hybrid system in hypobaric oxygenator. Please, Youssef, thank you.
Good morning. So really thank you to give me this opportunity to be with you, Professor Anastasis, but also Professor Polychronis. It's really an honor to be with you in the MiECC. So actually, I would like to start with this disclosure. I have a potential conflict of interest since I'm employed by Spectrum Medical as Director of Clinical Education. The objective of my presentation is not to promote the new hybrid system, and I acknowledge that the potential influence to this relationship may have a bias on the content. I am committed to transparency and welcome any question or discussion regarding this disclosure. So to start my presentation, if we look today to the unmet need, or if you ask any perfusionist or cardiac surgeon, what do you want to achieve in cardiac surgery? And you will see that all the benefit of MiECC that have been presented, and especially in this paper published in 2019 by Professor Anastasis, you can see that all the benefits that any cardiac surgeon and perfusion are looking is in the MiECC system. Reduction of the hemodilution, reduction in the transfusion rate, shorter stay in the ICU, reduction of coagulation for response and monoplatelet interaction, and reduction in the inflammatory response and the enhanced recovery after cardiac surgery. So my personal experience in MiECC started in 2002. So I started my career in 2002 at Hospital Saint Joseph in Paris with Dr. Yves Fromes. And during this period, the hospital was using this kind of circuit with the small console, HL20, two-position. We have the centrifugal pump, the oxygenator, the venous bubble trap. At the beginning, was using the collapsible bag, and later on, it was stopped by Maquet, and we started to use the reservoir. So during this period, really, I have the chance to be trained on the MiECC, and during this period, we was doing all kind of cabbage and aortic valve replacement, and it was the only indication. And then in 2004, 2005, Sorin Group introduced the ECHO, and the ECHO was amazing because we have this venous bubble trap, and with the application, the air purge control, where you have a sensor on the venous line, you can detect the air, and system automatically, let's say, can remove the air actively from the system. And it was amazing because with this system, we started to do all kind of cases at this time in St. Joseph Hospital. So we extended our indication to complex cases like Tyrone David, Bental, mitral valve, repair, replacement, any kind of surgery we was doing with this system. With this success, we have been approached by Sorin Group at this time to do proctoring for center interested in MiECC. So the beauty of this period, there was a lot of presentation on MiECC with the advantage of MiECC, like you presented yesterday in your presentation. People coming from EACTS, mainly cardiac surgeon, was interested in the concept of MiECC. So let's do MiECC. It was like this. We was invited by the company to come as expert and to do some training to start the program. And you will see that we go to the hospital, we present the concept of MiECC, we supported them in the setup, in the first 2-3 clinical case, and then we left the hospital. You will notify that after this, a lot of centers that started this approach, they stop because lack of knowledge, lack of experience. Perfusionists was not interested because they was not involved from the beginning. It was the idea of the surgeon. So they didn't say yes at the beginning. They started. So we see a lot of centers start and stop. And it was not really very consistent, this approach. In 2014, I have the chance to join Livanova as medical affairs manager in the Middle East and the international region. And you know, MiECC is a topic very close to my heart. So for me, really, the advantage of MiECC should benefit from a lot of centers. So we started our activity to promote MiECC extensively with the help of some of the key opinion leaders available with us today, Professor Serdar, Ignacio. So what we did that we started to look after the educational program because we felt that there is a gap in the educational program. And we did a lot in terms of training activity, including simulation, including a comprehensive program where the center interested in MiECC should follow a sort of education program with the help of Professor Serdar, where we go through all the aspects of the MiECC in simulation model, in animal model, before going to the OR and supported some cases. And we was doing this successfully for the last 6 years with a lot of on-site training and the clinical cases. The need coming, as you mentioned yesterday, from the expansion of mini-invasive program. So we saw today there's a lot of mini-invasive program coming outside with different hospitals, especially in the Middle East. And we see a lot of people was looking for optimizing the MiECC setup or the CPB setup. And you will see that Turkey was one of the most interested country in the MiECC. However, we have a lot of other countries like Saudi Arabia, Kuwait, Japan, India, Singapore, and Chile, where we did some activity, and they was really keen to move into MiECC. You will see that in 2003, we performed 1,500 case in Turkey, MiECC case, including cabbage, complex surgery, and let's say for sure aortic valve replacements, those kind. And the setup that we was using was somehow universal. So we didn't have the possibility to customize the custom pack. So here we are talking about Inspire 6 or 8, centrifugal pump, venous bubble trap, and the Medicard reservoir to manage non-activated blood during complex cases with association with the ATS. So, and this was working well. So the result of this, out of 18 cardiac centers in different cities, Istanbul, Ankara, Izmir, Konya, and other, with the support at least 5 clinical cases at the beginning, with more than 10 advanced courses that we deliver in a training research center where we have the possibility to do simulation, but also animal model before going and to perform the cases on the patient. We can see that out of those 18 centers, only 8 cardiac center is still using the MiECC for cabbage and aortic valve replacement. So today, my presentation will start from here because I will talk about the hybrid system. My concern is not about the 8 center because the 8 center now, they are in the state of the art. They are doing the best possible solution in cardiopulmonary with all the advantage of the MiECC that we know. However, we still have 10 cardiac center that we need to improve their clinical practice. We need to improve the outcome of the CPB. And this is where if we assess the problem of this 10 center, because today, if we look to this current problem and we discuss with any center doing MiECC, he will not acknowledge them. So we can manage the heart. We don't have heart distended. If you manage well MiECC, you don't have a heart distended. You don't have any problem with the anesthesia protocol. You don't have any problem with the accumulation of low DO2 and low flow because we know how to do MiECC. However, if you look to this 10 center, the main concern that they feel that it's complex to use with limited indication. So only cabbage, only aortic valve, where they want to extend to other possible cases. Also, there was a big discussion with the cardiac surgeons, the anesthesia, about the change, of setup of protocol, because we know it's more sensitive on the hemodynamic side. And for sure, for the surgeons, the most important aspect, working on a distended heart, is not optional. So he need really to be comfortable, especially with the mini-invasive setup. So having a good surgical field, it's very important. We notice also something that we have a lot of change in the flow during the MiECC because it is depend on the preload. So also we notice if we look to the area under the curve with the oxygen delivery, we have accumulation that can be really, we should be worried about it. And for sure, the air handling and the blood loss. The last point, and it have been discussed with Jenni presentation when he talked about the cardiotomy and vented blood, the use of ATS, The use of ATS is really very good, especially in cabbage, where amount of blood is very low. However, in our experience, autotransfusion was used in all the cases. And you will see in complex cases, when surgeons don't take care too much about the cell saver, and the amount of blood coming to the cell saver is more than 1 liter, here you start to have problem with the coagulation, especially for a patient of 60, 70 kilo, where you are losing more than 20% of the total blood volume, and you need to compensate with platelets, PFC. So all the advantages that we are trying to associate, we lose them somehow with the mismanagement, not with the concept, mismanagement of the suction line. So yesterday, Mike did a wonderful introduction about the importance of the venous reservoir, because we are talking about the oxygenator, how to improve the oxygenator. However, venous reservoir for a long time have been considered as a bucket, just to have the blood into a space, you know, with some filtration level. However, we know that interface with air, we know that also the keep it in contact with foreign material like silicone and the antifoaming agent. This is something really can have a big impact on the inflammatory response. So there was a lot of discussion long time ago about how to improve this, the design of the venous reservoir, and make it a little bit more physiological to be used. So first of all, the objective was to create something simple to use by anyone. We have passive effective air handling, minimizing the blood-air interface. We can use the VAVD because this is something really needed, especially with the mini-invasive. And we have the possibility to handle in a separate way the vent and the sucker. So Spectrum Medical was able to introduce recently to the market the hybrid system. It's combined of the best traits of the hard venous reservoir, soft shelf, and mini bypass. And all of this is combined into easy use system. So if we look to the functional design of this reservoir, you will see that it's really easy to use as a hard venous, like any hard venous reservoir. So it doesn't require any education or any effort to be adopted or to be implemented. It is safer than a venous bag because we know also the closed system have a lot of advantage. However, in terms of adoption, it have been always limited, the adoption of the closed system, due to the complexity to the management for the center not used to those kind of system. It can be operated safely with a very low volume and have a really superior air handling. The most important part that vacuum can be applied without any complication. And also we have this possibility to manage activated blood versus non-activated blood, because as you can see, the reservoir is divided into two chambers. In the first chamber, we have the non-activated blood. On the other chamber, we can manage the activated blood with the possibility to connect to the autotransfusion system and to process the blood through the autotransfusion system. I would like to present for you some internal data in vitro, because as you know, this product is really very new and there is a lot of amount of data available from cardiac center. So we did some tests internally regarding the air challenge. So measuring the air at the outlet of the reservoir. And you can see here in comparison with other, I didn't want to show the other as a trade name of other reservoirs. So you can see here in blue, the amount of bubble coming from the hybrid versus other model used with different flow during this test. And here also you can see the same test with no cardiotomy air versus cardiotomy air 300 cc per minute. And you can see the difference between the hybrid model and other model available in the market. We did also some tests related to the inflammatory and the interface of the blood with the air. And also here, it's amazing to see that we have a significant reduction in terms of air interface when you compare also the hybrid system to other system also available in the market. Our system can be combined with the hypobaric oxygenator. So I'm not going to develop or to talk about the hypobaric oxygenator because it's another topic. Just to highlight that today also we have an oxygenator where we can eliminate denitrogen completely the blood, and we can have a control on the saturation during the delivery to have a better control on the PO2. So the combination of the oxygenator with the centrifugal pump and the hybrid system really can give a very good alternative or option for the center interested in the optimized system and take the advantage of all the MiECC can do and applicated this on daily basis. So actually, also I want to present the early result of this study. We are doing an assessment of inflammatory response and the clinical outcome in cardiopulmonary bypass comparative study comparing 3 groups, the hybrid system, the MiECC, and conventional CPB system. We are doing this study with the help of Professor Kan Kirali in Koshulu, Istanbul, Turkey, where they have very big load of MiECC cases. So it was really very good to have the same setup for the 3 devices and also have the same surgical technique and have this comparison on the inflammatory response. So it is a comparative prospective study, and we are going to collect serum level of inflammatory marker, including interleukin 6, interleukin 8, tumor alpha factor, and with different type of measurement. The post-operative outcome will be also assessed, including the incidence of major adverse cardiac event, post-operative complications like stroke, renal failure, respiratory complication, length of stay and overall length of ICU stay and overall length of hospital stay. So just because we didn't finalize, so we are at half, of the study target, because here we are targeting 50 cases from each group, and today we are approximately around 30-35 patients in each group. So I don't have the details of all the data, but we noticed that in terms of interleukin 6 level, when we compare hybrid MiECC system, we have a lower in comparison to conventional group, which is something have been, I believe, demonstrated in many studies previously. For the interleukin 8, there was no statistical difference right after anesthesia and 5 minutes after bypass initiation. However, it was significantly higher in conventional group at 6, 12, and 24 hours. Tumor alpha was significantly higher in the conventional group versus the 2 other group. And until today, the blood transfusion rate also was significant lower in the hybrid and MiECC group. So just to conclude that today, MiECC, I believe, is the best option in cardiac surgery. And I believe we should use MiECC when MiECC it is possible and it can fit with the setup of the hospital. However, due to the complexities that we know and we discussed many times related to the education, related to the behavior, the interest of the cardiac center, today we can propose alternative, and this is what we call optimization. And today there was a lot of presentation about optimization, because this is something really can give all the advantage of the MiECC that we know today in an easy way for all those centers that they are looking for optimization, but it is not possible to adopt the MiECC. So the hybrid system really can be easy to use by any perfusionist, any cardiac team. We have a reduction of up to 600% in surface area compared to conventional setup. The impact on the platelet activation, really it have been approved, and now the studies that we are doing, and will have the result very soon, it's confirming this. We have a very limited air-blood interface leading for a significant decrease in the post-operative inflammatory response, low priming volume, and lower gaseous microemboli generation compared to the existing venous reservoir. Thank you for your attention.
Thank you, Youssef, for this really interesting presentation. There are questions from the audience, from the panelists. Please. So I have a question for you. Is really interesting, this innovative technology, in particular a focus of gaseous microembolic activity. Do you think that the future of the research is about the gaseous microemboli and the use of this system, for example, with the vacuum in the minimal invasive procedure? You think that improved this perspective?
Yeah, I believe there is a big area, and the space to improve this impact, because it have been discussed during many meetings. You can. I have been attending many EACTS, EBCP meeting. There is a lot of meeting ongoing where we are talking about the microemboli and how to improve microemboli. However, the system are still the same. So the same oxygenators that we have been using in the last 20 years is still the same that we are using today. Some improvement on the design of the arterial filter, but nothing major. So today I strongly believe that this approach, having new ideas, like Mike yesterday was trying to explain about LCD, but other possibility, to be improved. And hypobaric, I believe, is one of the innovation that really can make impact on this topic. So yeah, I believe there is the possibility today. Also, what you are doing, example now with your presentation, you are going to present the endocaviter. And this is something really very important, because you will see that the amount of bubble entering the system can have an impact on the amount getting out of the system. So also having improvement at this stage and this level, this is really can have a good impact, to improve those aspects during cardiopulmonary bypass.
Thank you, Youssef.
Thank you.
Great, thank you. I believe our next speaker is a pre-recorded